and I can give you the slides on this. Doesn't bother me at all. And yeah, like I said, please chime in if you have any questions. And I guarantee you, if one of you has a question, the rest of you all have questions. So please sing out. So we're just going to dive straight into proctology. So we're going to be really just looking at the common things today. So let's just jump straight in. Perianal sepsis. How does this normally present? Who wants to go first? Brent?
So perianal sepsis, usually we see a lot of these cases in our setting because of the high number of diabetics that are around. So usually the common presentations are these patients present really sick. They have perineal pain out of proportion, and they'll tell you that they have symptoms such as pus coming out or blood coming out of the bottom area, and yeah, usually they present very sick to us.
Yeah, typically it just hurts. Most people walk around without a bottom that hurts, and these people will come in saying, I've got a really sore bottom, and that can be from a number of different reasons, okay? But they'll have the caveat of there'll be something infective going on. They'll either have a fever, ruggles, shakes, or when you look at it, you can clearly just see that it's a perianal abscess. But really, anorectal suppurative disease can appear as acute anal sepsis. It can present as a fistula, as you said, with the discharging pus and blood. A fistula and an abscess, is important to note, can and usually do coexist until the fistula has been appropriately drained. And it's not always simple. It's not always like one external opening, one internal opening. Sometimes it can be quite complex, especially in people with Crohn's or TB. They can have, a bottom that looks a bit like a watering can and pouring pus out of everywhere. So just looking at this, who do we have here? Manoa, is your microphone working? Well, Jose?
Yes, sir.
Good. Nick all the way. All right. What's this? What are we looking at?
I look in the perianal area in the position of the patient in the lithotomy position. There is bulging or a lump in the anterior part of the anal, which is in the 11 o'clock position. That's one lump there, and erythema surrounding the perianal. So most likely that the perianal abscess.
Beautiful description. All right. So from an exam perspective, you're absolutely, everything you said was correct. Okay. All I would add to that is if you look at it and it is clear as day what you are looking at, you are always welcome to just say it. So if you looked at this in an exam and just said, that's a perianal abscess, your examiner might say, why is that? And then you just give them that beautiful description that you just gave. But if you look at that and you just go, boom, Nick, that's a perianal abscess, I instantly know, yep, I know what it is. And you've seen 100,000 of these and we just move straight on. But that was a very lovely description. All right. So perianal abscesses, what's the etiology? How do they typically occur? Like what causes them?
So the causes of death that mostly happen in that that's cryptoglandular theory. That's obstruction of the glandular gland. Cryptoglandular gland. That's which obstruct inflammation and obstructions in the glandular gland. That's why it causes in that this area, which is the collection of get infected and get collected, and later on can develop in the fistula, perianal fistula.
Perfect. So you've got the perianal gland. So the most common etiology is the cryptoglandular etiology, as you very accurately described. What are some of the other ones? Why else do people get perianal fistulas?
Unless some immunocompromised patients can get it, and some Crohn's disease, the patient can get it. And the patient
Well,
with diabetes also can get the perianal abscess.
yeah, immunocompromised, but Crohn's, TB, cancer. These are all very common causes of perianal abscesses that you do need to think about. So there is no doubt in the world that the most common is the cryptoglandular, but you always do have to consider the other causes. And you really need to consider the other causes of perianal abscesses when you've got someone, you know, what happens to the majority of these patients? They come in, you drain them, they go home, and you never see them again. People who've got complex or recurrent perianal disease, you've really got to be thinking about other problems, because sometimes it's the other problems that's, you know, causing this to recur, and that's why their disease isn't getting better. So you very, very well described the cryptoglandular theory a minute ago. So you've got so everyone's bottom is the same. Yours, mine, everyone's bottoms are the same. There's no real difference between any of them. Everyone's bottom's got glands in them. These glands get blocked. They continue to secrete mucus. That mucus gets infected. They develop an abscess. Bang, that's it, all right? Now, how do we treat? Is that what we go to now? Oh, sorry, yeah, where are the common perianal abscesses, where do they commonly occur? So not along the clock face. Is there any anatomical places or special different places that people can get, you know, perianal abscesses or anorectal sepsis?
I think the more common is in the at 3 o'clock and 3 o'clock. In the 3 o'clock wise, that's most common, and I think in 9 o'clock as well.
I'm pushing, you know, you're right. I'm pushing more towards, though, are there any special areas in the perineum that patients can get abscesses that you do have to think about that are slightly different? It's all right. So what I'm talking about here is places like the ischiorectal abscess, the supralevator abscess, subcutaneous abscesses, the interspherotic abscess. So the most common cause is just perianal abscess under the skin. It's like the first picture that I showed you. So the patient you were describing earlier, or, you know, the really sick septic patient with pain out of proportion to what you find, typically they'll have there what's called an ischiorectal abscess, okay? These can be huge, and these can make patients really, really sick. So the common perianal abscess doesn't make a patient particularly unwell. They've got a lot of pain, but you drain the pus, they're very happy and they go home. Ischiorectal abscesses, typically patients feel quite unwell, lots of fevers, lots of shakes, but you look at their bottom and you can't see a huge amount, and you're like, it doesn't make a lot of sense. But then you examine them and they've got a really boggy perineum, then you know this patient's probably got an ischiorectal abscess. Supralevator abscesses, I mean, these typically are associated with Crohn's disease, with diverticular disease and stuff like that. They're for a different talk. And then intersphincteric abscesses, which again, are pretty unusual, and typically these will just present as a typical perianal abscess. So just their perianal abscesses, as I said, certainly in our demographic, I can't speak to yours, but in our demographic, these small, like the picture I showed you at the beginning, that small perianal abscess is by far the most common, followed by ischiorectal, and then the other miscellaneous ones. So we've spoken a little bit about how they present: gradual onset of pain, pressure, fullness, fever. And it's really important just to note if they've had previous episodes of, you know, perianal or anorectal sepsis. On your physical exam, you're looking for localized swelling, hyperemia, induration, tenderness. The most useful thing I can say to do on a patient, if you can, you can't always because they're too sore, if you can do a digital rectal exam, specifically when they're asleep. Okay, so if you're doing an examination under anesthesia at the beginning of your case with your patient in lithotomy, when you do a PR exam, you can really feel where this problem is. Sometimes it's not clear, but if you sort of pinch the ischiorectal space when you're doing your PR exam, on the normal side, it'll feel completely normal. And on the side with an abscess, you're going to feel the big, boggy swelling. And realistically, the only way you can recognize that is if you've done a heap of them and you've drained a bunch of them, like I'm sure all of you have. That's a really nice way of knowing, you know, that's I'm operating the correct side, correct place, and I'm draining this well. So I examine you can drain these under local anesthetic, but local anesthetic and pus doesn't always go very well together, especially for the big abscesses. Typically, these people can need to go to sleep. And I cannot stress enough, if a patient you think has got perianal sepsis, you need to be sure you've drained it. So if you make a cut and you're worried that you haven't got the pus out, and it's a delicate area, you obviously don't want to cause harm. I've been in this position, all of my colleagues have been in this position where you've made a little cut, you're sort of like, goodness me, I thought there was going to be more pus than this. I thought this was going to be more dramatic. Using a needle, a 19-gauge needle on a 10 ml syringe to investigate the patient's perineum around where the swelling is. So you just dunk it into the tissue, suck it out. If you dunk it into an anorectal abscess and suck it out, you'll hit a boatload of pus, and then you'll click, you're not deep enough. And typically that is the problem. But if you're ever worried about where the pus is, 19-gauge needle on a syringe is very, very safe, and a very, very good way of examining the perineum further to make sure you've got no other undrained collection, bits of pus. Anyone have any questions about that? We're just going to press on. All right. So the treatment. Mauricio, you there, Mauricio? Maybe not. Anyone else want to put their hand up for how you drain perianal abscesses? Mate, hello? Good fella. Yep. So patient comes in, they've got a sore bum. What do you do? They've got it looks like the picture above that we saw. It's painful, it's swollen, it's red, got a fever. What do you do?
So if the patient comes with a sick patient, always we need to optimize the patient. The first thing, we optimize by giving antibiotic and painkiller, IV fluid. So treat that like a septic case. And then the principal approach of the perineal abscess is IND. We give the incision drainage regarding to the location of that it could be perianal or ischio-rectal or supraelevator or intersphincteric abscess. So, excellent. But the good things, but we need before we do the incision drainage, we need to do the examination under anesthesia to see that if there is any internal opening or external opening, so we can see if there is any fistula inside.
Okay.
Before we do the incision drainage. Yeah.
Very, very good. Well, I'm going to come to that internal opening thing in a second. All right. But you've said something really important about antibiotics. Do you give everyone? Keep going, Mauricio. You're doing really well. Do you give everyone antibiotics?
Yeah, it's because it's especially come with the abscess. Yep.
Yep. Do you give them once you've drained their abscess? Do you continue to give them antibiotics?
Yeah. Yes, I continue with antibiotic. After I drain it, at least I give it until 7 to 10 days.
7 to 10
because
days.
I want to send, because I give it the empirical at the moment, and then I send after the IND. After the IND, I send the pass for the culture sensitivity to know what type of the microbes that affected, so I can continue with the antibiotics after empiric. After I have the result of the culture sensitivity.
Okay. So I would say, in our experience, for patients with simple perianal abscesses, okay, people who are not immunocompromised, who don't have valvular heart disease or anything like that, if they've got a very, very simple abscess, like the one I said at the beginning, where are we here? Something like that. Once you've drained the pus, there's not a huge amount of utility of giving them a week of antibiotics. because once the pus is out, the patients typically get better. Now, everyone I give antibiotics to when they come into the hospital, because I don't know when I'm going to get them to the operating room. And when I'm resuscitating someone, in the setting of sepsis, yeah, you give them antibiotics, of course. But I would say once you've drained the pus, if there's not a lot of erythema and induration around the area, and if the patient's not immunocompromised, I would, speak to your consultants, but there's not a huge amount of evidence for giving people prophylactic antibiotics once you've drained the pus. Once the pus is gone in a simple abscess, typically you don't need to give them antibiotics. And the second, but aside from that, you're exactly right. Rule number one, treat the physiology first. Resuscitate the patient. Fluids, analgesia, all that kind of stuff. Incredibly important. Now, with regard to draining a perianal abscess, you do a radial incision or a cruciate incision? As in you just do a cut?
Cruciate incision.
Good. I'm just letting you know, it doesn't matter. I think cruciate incisions are better, personally, because I think they don't close over as quickly and they drain better. But people do radial incisions, cruciate incisions. I always, when I was junior, I was like, does that matter? And all I know is the more senior and older consultants all did cruciate incisions. So I just did exactly what they did. Now, I think it's good to examine the patient's parent, obviously do an EUA. I will say this though, when you're looking for an internal opening, in a patient who's got an acute perianal abscess, this is the first time they've come in with one. They've never had an abscess before. We're really talking about the bottom that you're looking at there. I would not look too hard for an internal opening. And the reason I say that is you can give someone an internal opening if you try hard enough. The first time that you drain a perianal abscess, there's a 75% chance it will completely heal and the patient will never have a problem again. So that means only 25% of these people are going to potentially develop either a recurrent abscess or a fistula. If you put aceton in every single abscess you drain, you're committing every patient to aceton, which you don't necessarily need to do. So when I drain a perianal abscess, I typically, I'll have a look in with we call it an Eisenhammer or what a Parkes retractor, whatever retractor you use to examine a patient's bottom. Again, it doesn't matter. And obviously, if you can see a big internal opening that you can stick your finger through, that's a very different discussion. That's obviously never going to heal. But if the bottom looks normal, once you've drained the pus, I would not go probing or looking for an internal opening. I would leave that alone, all right? Just drain the pus and get out of there, all right? The patient will thank you much more. And if they do have to come back in the future because they have got a fistula or a recurrent abscess, okay, fine. That's what they have to do. Because committing people to aceton, it's a bit of a palaver to get rid of it sometimes. But other than that, loved your description. Resuscitate, antibiotics, take them to theatre. But I just say, yeah, it's always good to have a good idea of how long and who we give antibiotics for. But would that be common for all of you? Would all of you put patients on antibiotics on discharge? I'm just interested.
Yes, Nick, we do give them antibiotics for the first 5 days at least.
Okay.
I think it's just because of the climate and the amount of it's actually the abscess that we see here are way, way big. Like they always come when everything's been taken, like they've tried everything else. So I think that's why we give them antibiotics. Yeah.
So in that setting, if they've got a lot of induration and swelling around their perineum, that's completely reasonable. All right. Very, very, very reasonable thing to do. Okay. But yeah, extensive associated cellulitis, those are the abscesses that have been cooking for 15 days or 2 weeks and they come in. They absolutely give them antibiotics. But if you're lucky and you've got them early, you don't always need to. All right. Continuing on. All right. I mean, some people would say draining abscesses in many different ways. I'm going to level with you. Abscesses are all drained the same way. Make a cut over the top of it, let the pus come out. There's nothing too exciting about that. So, second case. Who wants to do this one? Javili? And by the way, I do sincerely apologise if I pronounce your names incorrectly. That's on me. I'm very, very sorry about that if I do. But Javili, are you there? Maybe not. Or Sonam? Oh, no.
Bula, sir,
Oh, yeah.
I'm driving at the moment.
Oh, no. Keep driving. Ignore me. You're off. Bad luck. No, not you. Anyone else? Someone else. Someone who's not driving, please put your hand up. No. What about Sonam? Sonam Sharma. You there, Sonam? Pardesh, you're up again.
So Mano, yeah.
Mano, fabulous. Thank you kindly for putting your hand up. So, second case here. Patient presents recurrent perianal sepsis. They're pretty well, okay? They frequently have this discharge on their underwear, and patient says the wound dries up, but then it recurs frequently. What are we looking at here?
So you can see this discharging sinus on the left perianal region, which is just above the ischiorectal imaginary line, and this yellowish pus discharge, and also looks like this pus also coming from the anal canal. So it looks like these are communicating, and it's erythematous all around the sinus on the left buttock gluteal region.
What is it?
So the worrying issue we worried about is if the patient has necrotizing fasciitis.
Could be. I'll say the patient's really very well, mate. Really well. They've had a bunch of abscesses in the past, and they're not immunocompromised. They're a 25-year-old uni student. Does that make you think of anything else?
The other differential I would think of is fistula in anal.
Beautiful answer. Very, very good. I agree. All right. So this is a very, very common story for perianal fistulous disease. And that does sort of feed into a lot of this stuff. In patients with proctology, you can typically you typically get the diagnosis just from talking to the patient. You don't really need to look at the bottom before you know what's going on. Well patient, lots of bum abscesses. They've got this wound that's sort of draining and not draining. Have a look at it like that. Bang, perianal fistula. Very nice. So while we're talking about that, what is a perianal fistula?
It is a communicating epithelial tract that's it is a communicating tract between two epithelial openings.
Beautiful. And in the setting of a perianal fistula, what are those two openings? What are those two epithelial surfaces?
One can be the granulation tissue. One of the opening could be from the external around the perianal, and one could be interior or in the anal canal.
Perfect. All right, mate. I guarantee you, for the rest of this talk, I'm not trying to trick any of you. All right, you're exactly right. From the anal canal to the skin around it, of the two epithelial surfaces, and your description of a fistula there, textbook. Abnormal connection between two epithelialized surfaces. So exactly right. From the internal anal canal to the external opening to the skin. Where do perianal fistulas commonly occur? There's two kinds of, if you were to describe the perianal fistulous tracts, how would you describe them?
You have the intersphincteric fistulas,
Excellent.
the transsphincteric fistulas,
Perfect.
and suprasphincteric fistulas. This is in relation to the anal sphincters.
Absolutely right. Perfectly described. And do you know what that classification is called?
Sorry, can't recall the name of the classification.
I personally think eponymous names are stupid, because like, why do these people deserve to be famous? But that's called what you're talking about there is the Parkes classification. All right. So intersphincteric, transsphincteric, submucosal, which actually wasn't one of them, and suprasphincteric. Exceptional. So and you're, as you very correctly said, but it's in relation to the anal sphincters. Internal anal sphincter, just quickly, Manal, what is the internal anal sphincter continuous of, and what's the external anal sphincter continuous of?
I think the internal anal sphincter is anal sphincter is the continuation of the mucosal layer of the anal canal, whereas the external anal sphincter is the muscles of the pelvic floor.
Perfect. Okay, so well, semi-perfect. So I'd say that the internal anal sphincter is a continuation of the circular muscles of the actual gastrointestinal tract. So, you know, like when you look at the gut or like the large bowel, you've got the inner circular and the outer longitudinal muscles that, you know, that make up, you know, pretty much all of the gastrointestinal tract aside from the stomach. The internal anal sphincter is just you know, a thickening of the inner circular muscles of the gastrointestinal tract and lower anus. That's all it is. So if you look at those muscles, you can just continue to examine them straight up, and then you're just looking at the inner circular muscles of the rectum. Whereas the external anal sphincter, as you absolutely correctly said, is a continuation of the pelvic floor. So you got insphincteric abscess, transsphincteric, suprasphincteric, and extrasphincteric from above. This is the traditional Parkes classification. Now, as far as the frequency of these goes, do you know, while you're doing very well, do you know which one, do you know what the most common and the least common is?
I'm not too sure which one is the most common.
Okay. Yeah, so on my next slide, I've got numbers that came from a British trial from a number of years ago. And I personally don't actually agree with these numbers, because they say that intersphincteric is the most common, followed by transsphincteric, and then suprasphincteric. And the reason I don't agree with this is because the external anal sphincter inserts into the perianal skin, essentially. Like it continues further down than what it actually is. So I personally think intersphincteric fistulas, pardon me, are very rare. Very, very, very rare. It is possible that they could occur, but I think the grand majority of fistulous disease is realistically a transsphincteric fistula. Okay? So, how do these people typically present? Perianal fistulas, how do they present?
Most of them generally present with perianal discomfort or pain, and also discharging from the perianal area or the sinus that's around the anal area.
Perfect. Exactly right. They complain of either recurrent abscesses or just this wound on their bottom that's not healing. And, you know, they either have to wear a pad or they're just constantly feeling like they've, you know, a little bit soiled themselves, right? So history of perianal abscesses is very common, and they can be pruritic. What does pruritic mean? They've got an itchy bottom. Why do they have an itchy bottom? What's the most common cause of pruritus ani? By the way, this is going to be a question in about 10 minutes. What's the most common cause of pruritus ani? Like why do people get pruritus ani in itchy bottoms? This is something I didn't know until my exam, really. It's from moisture. People who have itchy bottoms typically have got a little bit of fecal incontinence. They've had diarrhea. For whatever reason, they've got poor anorectal hygiene and their bottoms are moist. And that's why they get an itchy bottom. That's the most common cause of pruritus ani. Or they use soap to wash their bottom and then wash off the natural oils that are present in the barrier. So if you can get people who have got pruritus, get their bottom dry, pruritus goes away. Anyway, we digress. We'll come back to that. So perianal fistulas. You do your perianal examination, DRE, you can do anoscopy in the outpatient setting because typically these people don't come to the emergency department. And I wasn't going to ask you to do this because to list these things off, but realistically, every time you do an examination under anesthesia of a patient with a perianal fistula, these are the things that you need to document. All right, so that the next person who operates on them or you who operate on them in the future know exactly what you're looking at, okay? You wanna know where the internal opening is, where the external opening is with regard to the clock face, okay? And distance from the anal verge, because, you know, at 3 o'clock, 1 centimeter from the anal verge and 3 o'clock, 5 centimeters from the anal verge is a bit of a different fistula. Location of the primary tract, which is the main tract. Are there any secondary tracts that are draining? And always, always, always determine if there is an underlying problem. And by underlying problem, I mean Crohn's disease or UC. All right? Oh, sorry, Crohn's disease or TB or whatever. So what is, this is a very good one. Who knows? So no, while you're on the spot, mate, you're doing well. What's Goodsell's rule? Have you heard of Goodsell's rule?
Yes. So Goodsell's rule is like a guide that we use to try and determine the position of the tract of the anal of the fistula. It is described as taking into account the like making an imaginary line across the two ischial tuberosity. So if the anal fistula is above this imaginary line, then the tract is most likely to be in a radial position, whereas the anal fistula that's inferior or below the below the ischiorrectal imaginary line, then it is the tract is guessed to be in a curvilinear position, like curvilinear tract, and anal fistula that's about more than 3 centimeters of radius from the anal canal would be positioned like radially.
So I like what you said at the beginning. Goodsell's rule, you know what you're talking about. You just got to keep it simple. Goodsell's rule, if it's in front of that 3 to 9 o'clock-ish, you know, between the tuberosities, in front of that, it drains radially, perfectly. If it's behind that, it's not necessarily curvilinear. The internal opening you expect to be at 6 o'clock. Okay, so in front of Goodsell's, in front of that line, radial drainage. Below that line, you're expecting the internal opening to be at 6 o'clock. Okay? And I like that you said it's approximately. It's not always. This is not written in stone, and this doesn't always happen, but typically this is what you will see. Okay? Now, special studies. In patients who present with a perianal fistula, it's reasonable to do a sigmoidoscopy or a colonoscopy. It's always important, I think, to exclude neoplasms, IBD, and associated secondary tracts, because it really changes what you do and what your definitive treatment is. Now, moving on to the treatment, again, the most important two things, if you're going to take anything away from the treatment of fistulas, the only two things that are genuinely really important are one, control the sepsis, and two, treat the underlying cause. So if a patient has got Crohn's disease or TB or anal cancer or anything like that, and they've developed a fistula, you're not going to fix this problem until you've treated the underlying cause. And secondly, always control the sepsis. So cetons, which we're going to come to in a second, are what really make the biggest difference in all of these patients, because they allow for adequate drainage, decreasing the abscess size and burden. And realistically, you can leave a patient with a ceton in forever. You never need to remove it. We have a number of patients who are very, very happy just living their lives with a ceton without having anything else done to them. Okay? And you've got different things such as definitive treatment. But what is a ceton? Manoa, what is it?
To my understanding, we usually use a non-absorbable suture to place along the inside the tract, so it allows granulation of the tract, and hopefully it occludes the tract.
Yeah. So exactly right. You put something non-absorbable. So we typically would use a vessel loop because they're quite comfortable. If you're using a non-absorbable suture like Proline or nylon, it can be quite pokey. And people's bottoms are a little bit sensitive and they don't like sharp, pokey things poking into them. So if you're going to use something non-absorbable, you'd be thinking something like a silk stitch. But I imagine you guys have got access to vessel loops. I could be wrong. They're very, very, they're very nice and gentle to use in the anorectal space. And exactly that, you're just putting it down the track. Okay, you don't force it down the track, use a fistula probe. And in doing that, that allows the abscess cavity, sort of like on that picture on the right, to close down around the ceton. All right? It means the fistula will never heal. Whilst there's a ceton in it, the fistula will never heal, but it controls the infection. Okay? So yeah, it's a foreign material inserted in. Everyone can have them. It's fabulous for those really complex perianal horseshoe abscesses. You know, those people who come in with the bottom just looks like a watering can. Those people, you put a ceton in, one into the internal opening, and then connect their other, collections together. Not quite like that, but if you do that, essentially it saves the patient needing recurrent dressings and all that kind of jazz, and allows everything to drain very nicely and can make a really complex problem quite a simple one. In patients such as those who have got Crohn's, Crohn's or immunocompromised, or are incontinent to start with, or anterior fistulas in women, this often is the maximum treatment you would do. Okay, you wouldn't do any more than this. You put a ceton in, you can leave them forever. It's very, very safe, because the next best treatment to a ceton is a fistulotomy, where you just cut, the line open. Now, this has got the best cure rate for perianal fistulas, but the risk that you run into is incontinence. I've said they're a big risk. It's not a big risk actually, but if you divide too much muscle, you've done the patient a disservice. So the rule of thumb was always, in men, you can divide 25% of the sphincter complex posteriorly and anteriorly 25%. And in women, posteriorly 25% and 0% anteriorly. I have to say, I'm very hesitant to divide any sphincter in a woman anywhere, all right? Certainly if they've got continence problems, because you can really do damage. But at the same time, it is safe up to 25%. That's been well proven, and specifically in men, they've got quite a lot of sphincter posteriorly. And the final thing I'll just quickly touch on, anorectal advancement flaps. This is where realistically you just leave a ceton in for a period of time until they've got a long, thin tract, cut a little flap of rectal mucosa and pull it down over the fistula, the internal opening. And what you're trying to do there is just obliterate the internal opening and hope that the perianal fistula gets better. Looks a bit like this. Now, there are heaps of other treatments for fistulas, such as lift procedures, such as fibrin glue, such as laser, such as collagen plugs. All of them have got about a 50% success rate, which means none of them work particularly well. All right. The one that works very well is fistulotomy and a aceton. These are the two things will get a aceton will get every patient out of trouble and keep everyone safe. Do you have any questions about that before we move on?
Sorry, Nick.
Yeah, go.
You have not mentioned anything about fistulectomy, taking a whole fistula tract out.
So, yeah, mainly we wouldn't normally. The question is why would you do that? What are you aiming to do with it? Like the question would be what are you aiming to do with a fistulectomy?
So we've seen few done by our senior colleagues here. It's usually the small, superficial, simple fistulas that are not passing through any of the sphincters. So those ones, they just take the whole tract out and lay that thing open to granulate up.
Pardon me. That's what. So when I say fistulotomy, that's what I'm talking about. Just dividing the fistula open and laying it open, so that you debride the tract that's there. I think we're talking about the exact same thing. That is the best treatment for perianal fistulas that are not involving really any of them, because it means they don't recur. But when people talk about, some people talk about fistulectomy, they're talking about like transficteric fistulas and they core the tract out through the muscles and stuff like that. Not as ideal, but if you're just cutting the skin and cutting down onto your aceton or wherever the tract is, that's the best treatment you can do, okay, for a perianal fistula. That's got a 100% cure rate, essentially. So that's a very, very good treatment. Okay?
Thank you. Yeah.
That's all right. Any other questions?
Sir, I just have a question regarding the aceton.
Yeah.
How often do we usually review, and when is the best time to remove the aceton?
Yeah. So I personally, anytime I do any anorectal operation on a patient, I'll see them 2 weeks afterwards, just to make sure that they are better and they're not unwell and there's nothing that I'm missing, because you don't want to do a procedure on someone, have them inadequately drained and they get worse. And I do that for any perianal abscess or any patient who I've put a aceton in. Once you've put a aceton in, you've got time on your side. And what you use that time to do is to work out what the anatomy is and work out if there's any underlying problems. So once the aceton's in, that's when you look for Crohn's disease. When you're doing your EUA, you can do a biopsy of the surrounding internal, opening tissue, see if the patient's got TB. You can wait essentially for all of those results to come in, because as I said, the most important thing you have to do is treat the underlying cause. So once you've worked out what the underlying cause is, which may be nothing, it might just be the patient's got a bad cryptoglandular abscess that's turned into a fistula, and that's fine. But once the patient's adequately medically treated, all right, that's when you can think about taking the aceton out. Now, what I will say is, if a patient's got if the patient's got no cause and they've developed a fistula, they're probably not going to get better with doing nothing and just taking it out, because the internal opening is still just going to be there. It's not going to get better. In conditions like Crohn's disease, though, there's no real consensus on this. The literature is a bit unclear, but typically once the Crohn's is under control, you should be able to, you potentially can remove the aceton and the tract will hopefully close over, because the transmural inflammation that caused that internal opening will have gone away. So in these patients, it's usually after the first few doses of steroids or whatever. Like again, this is an art form, not a science. I had one boss who used to wait for 2 doses of infliximab to be given before he would remove aceton. Other people would wait after 6 doses. Other people would wait for complete remission, and other people would just never remove it. But realistically, you put the aceton in to buy you time to work out what the anatomy is, treat the underlying cause, and then work out what definitive procedure you're going to do. Okay?
Thanks.
That's right. Anyone else? Nope. Pressing on. And just quickly, fistulas in immunocompromised patients. So this is actually just abscesses and fistulas. So people with HIV, 6 to 34% of them will develop perianal fistulas at the time. The more immunocompromised a person is, the more likely they are to get an infection. You can still do fistulotomies in people with HIV. And for complex fistulas and deep, bad transficteric ones, cetons are often the best treatment. And similarly for Crohn's disease, very, very common. They get abscesses. These patients will often develop a fistula. Just like a normal perianal abscess, you drain it the first time. When they develop a fistula, come back and then put your aceton in. Don't probe them too hard the first time because you don't want to give a patient with Crohn's disease 2 internal openings. They've already got one. You just want to use the one that they have. So you want to try and let some of the inflammation settle down before you put the aceton in. Anyway, that's just getting a little bit off the boil there. It's just, you really need to treat the underlying Crohn's disease before you take it out. All right, next case. I'm going to speed up a little bit. So 34-year-old woman, right, painful PR bleeding. Got a picture here of what it looks like. Cesaltina. I could be saying that wrong. I do apologize. Or anyone else? Paige?
So this.
What are we looking at?
This looks like a anal fissure in this lady, a chronic anal
Bang.
fissure.
Perfect. Love it. Like I said, in an exam, you see the answer, just give it. Boom. What's the pathophysiology of an anal fissure?
So the pathophysiology of anal fissure is it's a traumatic tear in the anoderm. It's usually in the lower part of the anoderm. The main pathophysiology is these people have a higher anal pressures or a very tight internal sphincter, which causes ischemia, a decreased blood flow, and hence this fissures don't heal.
Exceptional. Exceptional. All right. Tear in the anoderm, distal the. Did you write the slide? You may as well have written the slide. Tear in the anoderm. Perfect. Exposes the internal sphincter. So, like I said, under the mucosa, realistically, all you hit is internal sphincter. And the internal sphincter doesn't like being exposed to air or poo or pain. And anytime you poke a muscle, it spasms. So in these people, every time after they defecate, they get terrible pain in their bottom. All right? Feels like they're sitting on a knife. That pain is the muscle spasming. And just like any muscle that spasms, if it's too tight, decreases its blood supply, causes the fissure, doesn't heal. Excellent. Beautiful description. All right. So how do they present? Typically, the etiology of perianal fistula, local trauma from hard stool, vaginal delivery, anorectal intercourse, or secondarily from things like Crohn's disease, malignancy, TB or sarcoid. And it's just pain with bright bleeding. And typically these people are younger and incredibly anxious because these things all feed into each other. You can't be sitting there petrified of pooing because it hurts too much. That really weighs on people's psyche. They really get very anxious about it. And then you look for it and you see exactly what you saw there. Sometimes they've got a little sentinel node, a little sentinel like skin tag. You examine the bottom, it's incredibly tender. What I will say is, if you suspect a patient has got a perianal fissure, don't do a PR exam. That's a really mean thing to do, okay? Based on history, you can start treating them and hope that it gets better. And if you need to take them to theatre and do an EUA, that's fine. But doing a PR on a patient with a perianal fissure is not going to tell you anything, and it's just going to hurt the patient. Okay. I've seen a lot of registrars and residents doing that, and like it's very unkind. So investigations, realistically, these are, I personally think, largely optional. All right. If you have a really good story and a good examination and you can see the fissure, treat it. You don't need to organize the patient to do a sigmoidoscopy unless you've got another reason to do it. Like, unless you're thinking about something else. It's a chronic fissure that hasn't gotten better, or patient's got cancer and it's not, they've got cancer because of weight loss and tenesmus or something like that. That patient, different. That person, you need to be, investigating them, but you're investigating them for a different reason. Not necessarily for the fissure, you're worried about something else. But in a 24-year-old girl who comes in with severe perianal pain, examining them is optional. It's pretty much a very clinical diagnosis. Okay? So, perianal fissure. How do we treat it? Well, how are you going to treat it, I should say?
So the management of fissure, involves, first of all, I divided it into conservative, medical, and surgical management. And the conservative part of this management would involve starting her on high fiber diet, stool softeners, allow her to have sitz bath, and some pain relief medications or gels or ointments that she can apply. And these are the things that we change and try to see if the patient actually gets better with a very small acute fissure in ano. If it's a chronic one, if she is a young patient not willing for a surgical intervention then and there, we can start with the gels, nitroglycerin gels, oral diltiazem gels, nifedipine gels, and all those things. And also, we don't have botulinum toxins here, but I've read about the use of botulinum in these patients as well. And if all this fails, then we offer them surgery. The surgery involves either you can do a lateral sphincterotomy, or further advanced things which I have not seen is fissurectomies and flaps that you can do for these patients. So that's my outlined treatment of fissure.
Perfect. You say that in an exam, you pass every day of the week. Okay? So it was always described to me as there's 4 things you can do for perianal fistulas. Sorry, perianal fissures. Conservative, which is exactly as you said, appropriate toileting. So you don't want these patients to have hard stool, and you don't want them to have diarrhea. You want them to have that good, pain-free, once a day, regular bowel motion, okay? Because that's going to be the least traumatic to the anal canal, okay? And that involves, in most people, having a chat to them, working out what they're doing. These people typically will have started to try and do something themselves because, as I said, being afraid of pooing is horrific. So they may be you just talk to them, they may be overdoing it with the stool softeners and they've now got diarrhea, or they may just be absolutely petrified of pooing to the point that they are completely constipated. And as such, you need to, educate the patients that if you have good regular bowel motions, the pain will go away. And if the pain goes away, the fissure is starting to heal. Now, I personally, with these patients, if they've got a fissure, I implement the medical treatment, and I will also start them on something topical at the same time. Because once you've started them on the stool softeners, if they've really got a perianal fissure, you're better off, it's always nice to say, do this and come back in 6 weeks. And then when they come back in 6 weeks, they've still got it. All right, you've got something else up your sleeve. But realistically, you just want these people to get better soon. So start with the topical GTN or the nifedipine or diltiazem or whatever it is you have access to, all right, when you see them the first time. Because fingers crossed, they improve their toileting, they do the topical treatment, 3 times a day, twice a day, and they get better. And then you don't see, you see them again, they're improved, and you can discharge them. Botox, you haven't got access to that. I mean, Botox is something that can be used, all right? It's sort of like a temporary sphincterotomy, so to speak, a very good question for you would be, does Botox actually work on smooth muscle? And if it doesn't work on smooth muscle, why does it work with perianal fissures? But at the same time, that's a topic for a whole other topic for another day. But yeah, realistically, it's like a temporary lateral sphincterotomy, because a lateral sphincterotomy is an incredibly effective treatment for a patient with a perianal fissure. Once you have done the above treatments, okay? And usually you give these people 6 weeks, 8 weeks of trying, you know, the first 2 treatments before you consider going to the next one, okay? And what I would say is also, if patients are improving, keep going with it. So a patient may present with a perianal fissure, okay? You do the above, you know, you do your conservative management, they start to get better. Just because they come back in 6 weeks and have pain, don't say, oh, well, that's failed, press on, do an operation. No, keep going, because it may just get better. So, the management goal, as I've said there, you got to break that cyclic perianal spasm and prevent the tearing of the anal mucosa. That's how you promote the healing. Okay? Other thing I'd say, from a lateral sphincterotomy perspective, and I can give you guys these slides, you only need to divide the sphincter to the top of the fissure. Okay, some people talk about different heights of a lateral sphincterotomy, et cetera, et cetera. You obviously do a proper EUA, make sure you're not taking too much, but you only need to divide it to the height of the fissure that's there, because that's the associated muscle that's spasming and preventing the healing. All right, another case. This is a bit of an easy one. This is, oh yeah, no, go, yep. Like I said, don't put your hand up. If you have a question, just sing out and say, Nick, stop talking, and I'll go.
Yes, Dr. Nick. So I've read about it, anal dilatation in fissure in ano, and that's a practice that has now been put away. But I've seen my seniors do it here, and the outcome is really good. What are your thoughts on anal dilatation in these patients?
So that is a very controversial topic. I'd say this. When patients get things like Botox, or whenever you examine a patient or go to do any procedure on them, I'm sure most of you examine these patients, you do a PR exam, they've got an incredibly tight anus. And doing anything to examine them with a Parkes retractor or something like that does involve some form of anal dilation. But the retractors that we use, like just to get a Parkes dilator in, you would expect that's not going to cause a significant amount of trauma to the anal sphincters. It used to be called a Parkes stretch, where the patients used to put an Eisenhammer in and give the patients a good stretch. Now, I'm not here to talk, like your senior colleagues and your consultants do what your senior colleagues and your consultants do. What I would say is the danger of doing that is you can just disrupt their sphincter complex completely. And in doing that, it's historically, because it's, some people may have a technique that works very well, but historically it was shown that it caused really large numbers of, disruptions to the sphincter complex and can result in bad incontinence. And that's really not what you want to do, especially when, as I said, all these patients need from a sphincter division perspective is dividing the internal sphincter to the top of the fissure. So so giving them a good stretch, like what they used to talk about doing, can cause more harm than good. I personally don't do it, but I do recognize when I put Botox in to a patient, I'm giving them a little bit of a stretch, in the sense that I have to be able to see where the sphincter complex is with a St. Mark's retractor, with an Eisenhammer retractor, pardon me, or a Parkes retractor. So that is technically giving them a little bit of a stretch, but I'm definitely not, giving them the whole hog and, ripping them in half. That's you got to be very, very careful with that. But it's a very good question, and it is practiced, and it is very effective because, when patients get a stretch, what that does do is that can disrupt the sphincter complex and the fissure heals. Does that answer your question?
Thank you. Yes, Dr. Nick. It's just that I
Yeah,
brought it up
yeah,
with my consultant one day through my reading, and
yeah.
he said, "Show me a patient who did not have a good outcome," and I was dumbfounded then. Yeah.
Well, I mean, he's not lying, okay, but in the sense that you do, you do have to use that cautiously. I would say that a lateral sphincterotomy is a far more precise way of doing essentially what you do there to make that better. Okay, you know, but at the same time, I'm not discouraging what your consultants are doing. That's not at all what I'm trying to say, but that's the downside of doing a park stretch.
Thank you.
You sure, Praneeth, it wasn't suggested because of your performance he was going to do it on you guys, or was not?
No, Dr. Nothing like that.
Well, that was just. I was waiting for that, Sonal. All right.
Praneeth looked too happy suggesting it. That's why I was just making sure that. Nick, I'll leave you to it. You guys carry on. That's good. Praneeth, hopefully we're getting a good attendance to these sessions. These people are spending a lot of time preparing for this, so ensure that we are getting maximum attendance on these things. And I always say I've got a long memory. I remember the topics covered, and I'll be examining this on the first week of December. So remember, guys, let's work hard.
Yes, thank you, Dr. Sonal.
All right. This sort of this pushed into the what we were talking about earlier. This patient, 36-year-old man, painful, itchy bottom. What is this? Let's go. Who we have before? Marina, you there?
I just let's put this on anyway.
A little bit of interference there. It sounds like you're still operating, Marina. I'm going to level with you. Anyone else? This is a little bit of light relief before we get on to some other stuff that's actually quite important. Here, go. Who wants to tell me? Just quickly shout it out. What do we think this is?
It's a pretty to honey. It's a look like the thickening of the anal birds, thickening of the skin. It's most likely pruritus of ani.
Pruritus ani, absolutely right. Love it. What I've already told you. What is the most common cause of pruritus ani?
That's the hygiene is the hygiene and the diarrhea. There's a lot of moist in this area regions that cause the itchiness, and then the patient like stretching a lot of that area, and it causes it's thickening the area.
Perfect. All right. So essentially, these patients come with itchiness and pain of their bottom. All right. The most common cause is moisture, and the most common cause of that is people who have got poor hygiene or who are too hygienic and washing their bottoms with soap. Cannot stress that enough. All right. So the treatment for this is to keep it dry, keep it clean, and it gets better. Some people you will see have used stuff like topical steroids. I say using steroids on your bottom, not clever. I would not put steroids on my bottom. I wouldn't put steroids on anyone else's bottom because steroids make skin thin. If it's some horrific version of it, try it for a few days, but I say use that carefully. All right. So local irritants, moisture, trauma, drugs, fine. Secondary to anorectal conditions, fine. But the problem is just moisture. History and examination. Again, you don't need to do much for these patients. You look at them, you talk to them, you look at their bottom and you see what the problem is and you just treat it. Okay? Similarly, do these patients need a scope? 35-year-old with an itchy bum doesn't need a scope? No, of course they don't. They've just, they've got an itchy bum. You've made the diagnosis. You know how severe it is. Unless they've got another reason, don't need to do anything. All right? So treat any underlying causes, good anorectal hygiene, remove the precipitating factors. I've written there topical steroids limit to 2 to 4 weeks. You know, that's what they say in the books. I'm just saying, don't do that. Like, be very, very cautious in steroids and bottoms, especially because if a patient's got pruritus ani and they have got some underlying cause and they put steroids on it, it will feel great. And it'll feel great until they stop taking steroids because you haven't treated the cause, and they're just going to keep on taking steroids and you're just going to annihilate the bottom. So be very, very cautious. So I've said last case. This is actually the second last case, all right? But I thought I'd fill you with some false hope. So I think, Jose, that you were there before. I think you chimed into the pruritus ani one, but I want you to chime into this one because it's actually a real case, unless there's someone else who desperately feels they want to have a go. But Jose, what are we looking at here? Anyone, or Marina?
Anal cancer.
Thank you. Excellent. Boom, 55-year-old. And why do you think it's anal cancer, Marina?
It's within 5 centimeters of the anus, and it's a fungating like tumor.
Is there any other hints I've given you?
Age, male.
One really important thing there.
Painless mass with bleeding.
So he's on.
What's the other thing that I've written there?
His post kidney transplant.
But as you know, you'll get. Yeah, Marina, renal transplant. Anyone who's really immunosuppressed, all right,
Okay.
high risk of developing SCCs. Really high risk. Okay. Now, Marina, I love it. You're doing well.
Yeah.
Tell me, what are the common anal cancers?
The most common is SCC.
Beautiful.
And
Exceptional. Yeah. Keep going.
you can have adeno cancer, but it
can.
is quite rare.
Very rare. Very unusual.
You can have perianal SCC or metastatic anal SCC.
Yeah, so where it says
I mean, sorry, perianal. Sorry.
Pardon?
That's the only. That's just the two that I know.
That's okay. That's right. You can also get perianal melanomas, but they don't look like this, okay? And they're quite rare. But Marina, now that I've got you, you're on.
Yeah.
So I'm going to be aiming the questions at you, just FYI. So I think this is probably, when you're looking at anal cancer, specifically anal SCC, when we're talking about anal cancer, we are talking about anal SCC, okay? This slide is probably the most important because anal SCC is a spectrum, all right? And it ranges from normal to invasive cancer. And the way that it goes via that is more and more dysplastic cells. So you start with condylomata. Marina, what are condylomata? Condyloma?
It's a fungating benign tumor that's called by HPV.
It's caused by HPV 12 and 6. What are they called? It's fungating. They're very small. They're frequent. They're really common. Warts. Anal warts.
Anal warts, right?
Yeah, anal warts. Really common. Okay. And then that progresses as you get more dysplasia to AIN, or what we call low-grade AIN. And then as you get more and more dysplastic cells, that goes to high-grade AIN.
Yeah.
Once it invades beyond the basement membrane, you have invasive carcinoma. Okay? Now, I know, unfortunately, I don't know why they've written HSIL. What we talk about now, the current nomenclature is low-grade and high-grade AIN. So low-grade AIN would fall into that AIN1 category, and then high-grade AIN is the 2 and 3. And once it goes beyond the basement membrane, it's anal SCC. Okay?
Okay.
Right. So, condylomata, anal warts. Sorry, I sort of cheated and gave you everything on the slide there, but I've now gone backwards. How do you treat anal warts?
Topical anti-ablation therapy.
Cut them out. Okay? Now, that's the easiest way. Some people use just burn them. Some people do use topical agents. In my experience, just cutting them out, very, very, like, it's the best way of doing it. You just have to recognize that you have to do it a few times because 50% of the time they come back. But they look like this, right? Small pockmarked lesions around the perineum, typically sexually transmitted, okay, but not always. But your treatment, yeah, you can use a Michelmord and interferon and all very expensive, all crazy. Get a, you know, put the patient to sleep, put some local anesthetic into it, cut them off, right? The patients will be fine. It doesn't hurt. Like, they give them a sitz bath and then they'll get on with it. They'll be all right. So that leads to AIN. What do we talk? Yeah. Do you understand? Have you guys ever heard of AIN? I imagine you have, but you may not have. So that's okay. It's all right if you haven't. AIN is the precursor to SCC. It's essentially these people, they have got these white waxy plaques on their perineum, okay, that when you biopsy them, get graded. Now, you'll be asking, Nick, why do we care about this? The reason you care about this is because every time you cut something out of someone or off someone, you send it for histology. If they've got warts or this kind of a lesion, you take a biopsy of it, it'll come back as AIN and you need to know what to do about it because you'll see this, the patient's going to say, do I have anal cancer? The answer is no, all right? But it depends, it really is it's just a spectrum. So how do you treat this? Because realistically, once you've seen it, you've got this big patch of AIN. What are you going to do? It's not cancer yet. So the answer to that, I think, is pretty simple. All right. You divide high-grade and low-grade AIN and high-grade and low-grade patients. So low-risk patients or low-grade patients are patients who are not immunocompromised, otherwise well, no other issues. High-risk patients, immunocompromised, men who have sex with men, HIV positive, long-term steroid use. They're the kind of people who would fall into the high-risk patients, okay? So if you think of that as a 2x2 table, which most of surgery is, it's just like low-grade, high-grade, low-grade, high-grade. Low-grade patient, low-grade AIN, you don't have to do anything. You can just surveil it. Low-grade AIN, high-risk patient, you need to treat it. High-grade AIN, low-risk patient, the verdict is currently out, whether or not we need to treat it, but you need to survey them at least in 6 months. High-risk disease, high-risk patient, you need to treat it, okay? And the treatment for these patients is topical therapy, realistically, all right? Just like a skin cancer that's in situ, use topical imiquimod or 5-FU and just gets rid of it. Does that make sense? Now, Marina, the real question, your only real question is anal SCC.
Yeah.
You've got a patient who's got a bottom wound that looks like the top one, the very first picture I showed you. They've come to your clinic. What are you going to do? This patient, they've come to your room. What are you going to do?
Probably stage them.
What's the first thing you're going to do?
Biopsy.
Always. First thing, Only 4 things we do as doctors ever: confirm the disease, determine its severity, implement treatment for that severity, and arrange follow-up. They're the only 4 things we ever do. So you think this is anal cancer or SCC, but you don't know that. So how do you confirm it?
Biopsy.
Yeah, good biopsy. You're exactly right. Perfect. Okay. Are you going to scope the patient?
Not until the diagnosis has been confirmed.
So I typically would. If a patient has got what looks like anal SCC and anorectal cancer, there's not an insignificant number of these patients who've got common colorectal cancers, and I think it's reasonable to scope them. But that depends on access, et cetera, et cetera, et cetera. So anorectal tumor, what do you do next? You've confirmed it, it's cancer. What are we going to do?
You'd stage them then.
How do you stage it?
So you could do a CT chest and an MRI of the pelvis.
So what are you going to do about the abdomen? You're going to CT the abdomen?
Right, yeah. So CT chest, abdomen, and MRI of the pelvis.
Yeah. So pretty much everyone's staging for all gastrointestinal malignancies is pretty much the same. Everyone gets a CT chest, abdomen, and pelvis. Everyone. Okay. In these patients, you're exactly right. It's reasonable to do an MRI of the pelvis. Okay. Where would a cancer like this send lymph nodes, Marina?
To the groin.
Beautiful. So you'd examine the groin. You can't really feel anything. What are you going to do about that?
You could still do imaging, because sometimes clinically you won't be able to palpate it. But
what's the best imaging?
It would be a PET scan, but we don't have that.
So I was going to say that's the next thing. There is something that you would have if you have a questionable lymph node in the groin.
Ultrasound scan?
Yeah, exactly right. You do an ultrasound of the groin, see if there's any big lymph nodes. Okay. And the other beauty of doing an ultrasound of the groin is if they've got lymph nodes in the groin and they're present, you can just get someone to stick a needle into them and suck out the cells, and you can work out whether or not they've got metastatic disease. Bang, done. All right. And then you said PET scan. Well, if you've got access to a PET scan, fine, you can do it. A lot of people would, but if you haven't got access to it, it doesn't really change anything. PET scans haven't been around for very long, so whatever. Now, what's the treatment for? You've confirmed it. This patient's got anorectal SCC, and it looks like that.
Yeah.
What are you going to do? How do you treat it?
So the primary mode of treatment would have to be initial concurrent chemoradiotherapy.
Perfect. What's the protocol?
I don't know the exact protocol. I just know the drugs.
Oh, that's even more impressive. What's the drugs?
So I know that you do use fluorouracil, and mitomycin.
I can't remember if it's fluorouracil. See, I cheated. We call it the NIGRO protocol, NIGRO, which is 5-FU and mitomycin C. Absolutely right. 10 points to you. Perfect. And concurrent radiotherapy. All right. Absolutely correct. That's the treatment. And if that doesn't work, Marina, you give them that, and they get recurrence, or it doesn't work, or they can't tolerate it, or they get pain. What are you going to do? What do they need?
Surgery.
What does that look like?
An APR.
Yeah, that's exactly right. So historically, these people got APRs, and then they found out that the NIGRO protocol was very effective, and they stopped giving them APRs up front. But your indications for an APR and anal SCC are a current disease, can't tolerate the treatment, okay, Sorry, I don't know what happened there. Apologies. Can you all hear me?
Yes, we can.
Yeah, sorry about that. Yeah. So salvage APR or recurrent disease or severe complications from your NAGRA protocol. But that's kind of a summary of what we do for anorectal SCC. But no, Maria, that was very good. All right. And then, yeah, clinically follow them up. Do you guys have any questions about that? No, just press on. Good. The last thing I'd say is this. I have seen this a number of times, like a number of times. Do not mistake the picture on the left for the picture on the right. Okay? Someone tell me, what's the picture on the left? Probably the most common perianal problem, and we haven't spoken about it yet. There's only one.
Looks like a thrombosed hemorrhoid.
Thrombosed hemorrhoid. What's the picture on the right?
Anal SCC.
Cancer. Do not make this mistake. Okay? The only way you make this mistake is if you haven't seen enough of it. But the key difference is the history. The patient on the left has had 3 days of pain. They can't sit down and do. The patient on the right might have pain, but it's been present for ages and ages and ages. They look completely different. And I, this year alone, have seen 2 or 3 patients who have had anorectal cancers that have been misdiagnosed as hemorrhoids. So that's just a really important, do not make that mistake. So quickly, this should be just money for jam. Anyone, hemorrhoids, what are they? Who gets them? What do you do about them? Mauricio, are you there? You still drive? Was it Mauricio who was driving before? I apologize, can't remember.
Chovili.
Javili. Oh, he knew I was going to ask him. That's why he signed off just at that exact moment. Manoa, you there, Manoa?
Yes, boss. So,
Hemorrhoid. Go. Tell me, who gets them? What do you do about them?
hemorrhoids are it's an abnormality in the veins of the anal canal. So when these veins are thrombosed or dilated, then they appear on the surface. For example, the internal hemorrhoids, which is above the dentate line, these are visible on proctoscope. They are bluish, purplish in color. And if they are below the dentate line, then they are classed as external hemorrhoids. So, yeah, and this condition usually happen in patients who experience or who use most of the who are in the washroom and use the washroom for prolonged time and use a lot of pressure in passing out stool. So they tend to have this.
People who push too hard. People who are a bit constipated. Very, very common.
Yes.
Which other groups of, exactly right, which other groups of patients frequently get hemorrhoids? to give you a hint. It's women. It's a very special point in their
Pregnant.
life.
Pregnant.
Very common.
Pregnant ladies.
Yeah, Thessalina, very good. Pregnant women, really, really common. Okay. So I'd say about this, about hemorrhoids. Hemorrhoids are normal, all right? Everyone's got them. Okay, it's a normal part of the vascular cushioning of your bottom. They do. Some people think of them as veins. Realistically, they're more like a sponge. Okay, they appear like a sponge in your anal canal. All right. Now, they only become a problem when they get too big or they thrombose. What do you do about it? What are we going to do about it? Cecil Tina. Mano's done very well, and he's already had a question. Cecil Tina, I can hear that you're there. How do you treat hemorrhoids?
So for the hemorrhoid, so we have to classify the external and internal hemorrhoid. So
Good.
For the internal hemorrhoid, so we normally we classify as a first degree, second degree, and third degree and fourth degree. So for the first degree is a bleed, but there is no prolapse through the anus. So the treatment is only medical. They serve the patient with a high fiber diet, with a seatbelt, regular seatbelt, and also we can recommend the patient with the steroid cream as well. The second degree is a bleed with the prolapse with the straining, normally in the patient with the chronic constipation, but reduced spontaneously. So the treatment that we can offer, we can offer a rubber band ligation, and the other one is photocoagulation. We can offer to second degree of the hemorrhoid. And the third degree, bleeding, prolapse, and need manual reduction. So the treatment, as I said before, we can do the rubber band ligation, and also may need a closed hemorrhoidectomy. And the third degree, bleeding and prolapse, permanently prolapse and cannot be reduced manually. So the treatment is, what we can offer is either closed or open hemorrhoidectomy.
Fabulous. All right. So one thing I would say.
Yeah.
Oh, sorry. No, keep going. Yeah. Keep going. No, keep going.
So for the external hemorrhoid is normally we just offer the medical treatment like increase high fiber diet, stool softener, steroid application as well. And for the thrombus hemorrhoid, that is normal, is very painful. So what we can do is we can consider the surgical compression of the thrombosis, or we decide with medical treatment, some analgesic for the pain.
Beautiful. All right. I think your description of the grades there is fabulous. Okay. I would say, again, like grade 1 hemorrhoids, steroid cream. You're not going to put steroid cream on anything. There's nothing really to put steroid cream on. But everything else was fabulous. Okay, so absolutely agree with you. Everyone gets a high fiber diet. All of the patients who've got in those bulky internal hemorrhoids, even if it's grade 3, you can still, do a rubber band ligation. That's completely reasonable. You might need to do it again. The really only patients you can't do rubber band ligation, which would be the most common thing we would do. I can't speak to what you guys do, but the most common thing we would do would be rubber band ligation for internal hemorrhoids. The only contraindication really of that is external hemorrhoids. Like you don't put a rubber band below the dentate line because that just hurts people. But there's obviously those grade 4 ones that look like the person's bottom is falling out. Those patients are the ones that you need to be thinking about doing a formal hemorrhoidectomy, either open or closed. Similarly, if a patient has got external hemorrhoids, I mean, you're right, you can treat them with nothing, but sometimes patients are going to want you to do something about them. The only treatment for external hemorrhoid, well, sorry, pardon me, not the only, the most common treatment for external hemorrhoids would be a formal hemorrhoidectomy. Okay? Now, there are groups of patients you need to think a little bit more about. Okay? For example, cirrhotics who have got portal hypertension, doing a hemorrhoidectomy, not clever. Similarly, doing a rubber band ligation, not clever. Okay? Because these patients' underlying problem is portal hypertension. So in these people, you can consider a hemorrhoid artery ligation, for example. Similar to that, pregnant women, as you very accurately, so let's do how pregnant woman comes in because she's worried that she's got prolapsing hemorrhoids. What are you going to do? She's second trimester.
I would recommend her on medical treatment first, rather than offer the surgical treatment. So maybe for the surgical treatment, I can wait until she deliver, and then I offer the surgical treatment for her.
Perfect answer. Okay. Pregnant people, don't do things to them unless you have to. Most women, when they get pregnant, will develop hemorrhoids, and most of those hemorrhoids will go away once the baby's been delivered. Okay, so they often won't need anything to be done at all. See if I've said on that. So fibromuscular cushioning of the anal canal, pathologic only when it becomes symptomatic, prolapsing. Again, patient's got hemorrhoids, you do your EUA on them when you're going to be treating them is ultimately the time that you do it. So behavior modification, as you very correctly said, increased fiber and fluid, stool softness, topical agents, rubber band ligation or injection sclerotherapy, and then surgical like an open or a closed. What do you guys more typically do? Do you guys do open or closed hemorrhoidectomies?
Open.
Open?
Milk and
Yeah, fair enough. Yeah, there's no difference, but yeah, it's just preference. That's cool. People do stable hemorrhoidectomies or suture hemorrhoidopexy. I would ignore that. Hemorrhoid artery ligation is something you may never have seen before, which would be reasonable. It's not super common. I've only seen it a few times, but that's a very, very neat solution for some people who've got bleeding and who are high risk, which is really, you know, you put your endoscope in, they've got a little special ultrasound that just finds the hemorrhoid, the feeding vessel, and you just put, using a UR6 needle, stitch the hemorrhoidal, you know, pedicle, done. Really, really, really lovely way of getting yourself out of trouble. And these are just the special circumstances. Thrombosed external, strangulated. In pregnancy, usually you don't have to do anything. Acutely thrombosed and prolapse, you can consider operating on them. And then patients with IBD, avoid operating on them. So that was my last slide. Do you guys have any questions that I can clarify for you? Nothing at all, not a problem. Listen, you should have my email. If you have any questions and that you're not comfortable asking, please feel free just to shoot me an email. I'm not always amazing at responding, but if you get it through to me, I'll write back to you. All right. Happy with that?
Thank you.
No worries.
Thank you.
Absolute pleasure. Yeah, no, absolute pleasure. Guys, go out and enjoy the rest of your night.
Thank you.
Thank you,
That's all
Dr.
right.
Nick.
Thank you.